who am I and why I'm here. So I used to be a pediatric epilepsy consultant in the NHS UK, and during that time, that was the time when epilepsy gene panels were emerging, and they were able to make a large number of hugely high impact, life-changing genomic diagnosis, which introduced us to the practice of precision medicine on day-to-day practice. So I was collaborating with guys in St. Thomas, King's College, and St. George's London at that point. So that's how I developed an interest in pushing for genetic testing in children. The next step, when I was working with the Alliance in south of England, my role was specifically in promoting whole genome sequencing in pediatric practice. So what I specifically used to do was going to different places, different units like neurodisability units, learning disability psychiatry, local hospitals, etc., to present with powerful clinical stories to prompt people to think about genomic testing in their children. And finally, in the current post, we have had the fortune to collaborate with Dante Genomics, which is quite a familiar name here. And in the last 2 years or so, we've made some really useful, high-impact genomic diagnosis in our patients. So you can call me as a clinical storyteller, because that's my specific area of focus today. So these are the few things I want to talk about today. The impact and potential of genomic diagnosis, and we'll look at that through a case story, and specifically looking at the clinician's perspective. So as I said, I'm a frontline clinician. I get 20 minutes to see a patient, and I see patients one after the other, bang, 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 bang. So there are peculiarities in which we make decisions on our patients. And mostly, if children or patients have to get genetic diagnosis, mainstream clinicians like me have to request for those tests. And using this case as an example, we look at the scope and challenges for the future. So I just want to touch upon the issue of rare diseases versus common diseases. We often think about genomics as something dealing exclusively with rare diseases. But if we ask ourselves the question, have we understood the common conditions properly? Perhaps not. Look, for example, epilepsy is a case. The incidence of epilepsy on the whole is 1 in 100. And we haven't probably understood our common conditions properly from the lens of genomics. Asthma is another example, and there are also lots of new genomic influences on asthma practice now coming up. So a few facts about rare diseases which you've probably heard many, many times, but I'll just quickly go through them again. They're individually rare, but collectively they form a big group of diseases. And 1 in 17 people will be affected by a rare disease at some point in their lifetime, statistically. So this lecture hall here, if there are 500 odd people, there will be about 30 people with rare diseases at some point in their lifetime. So it's not that rare, actually. And in UK, it's about 3.5 million people. And 80% of these rare diseases have a genetic component. And we all know the problems with how we diagnose rare diseases. We all keep talking about the diagnostic odyssey, which is the long and painful journey that these patients and children have to go through before getting the appropriate diagnosis. And that involves excessive resource utilization, both on the family of, both on the family and the public sector. And repeated investigations that we do, especially in children, come with potential of harm. For example, repeated MRI scans, repeated lumbar punctures, repeated blood tests, all have potential for harm. And most importantly, lots of these conditions can be reversed and prevented if we intervene in time. So we are missing opportunity to treat them on time if we don't diagnose them. So this case story, so we've taken a slightly different approach rather than presenting the overview of what we've diagnosed in the last year. We're going to zoom into this particular case, understand all these challenges we discussed about rare diseases and the biases that clinicians have in making these diagnoses. So this is a little baby born to a consanguineous Omani couple, and from 3 months of age, he unfortunately started getting recurrent multiple infections, mainly of the skin, lungs, different kinds of abscesses and things. And as usual, he would see multiple different doctors who would give him short courses of antibiotics and get better. He'll go to different hospitals who will admit him for drainage of abscesses and skin infections, and he would get better, but soon to come. He was referred to King's College in Dubai at 3 years of age. He was actually referred to my surgical colleague for skin abscess that was not healing for a long time. So I was sat next to my colleague's office. So he comes to me and said, "Look, this child's abscess, I don't think is much of a problem, but I think there's something else going on with him." And the reason for him to ask me was he noticed that through his investigations, he had raised IgE in 5,000s and 6,000s on repeated testing, and he had a bit of soft dysmorphism as well. So he handed over the case to me and said, "Anytime you need me to drain an abscess, call me, but this is your case now." So this is how clinicians make biased decisions. So I saw the word hyper IgE and IgE levels and recurrent infections. So I immediately thought that this was going to be one of the hyper IgE syndromes, and I made up my mind after a quick PubMed and Google search that these are the candidate genes I will be looking for. And I sent the genetic testing, but somewhere I had a sense that because of consanguinity, dysmorphism and things, maybe there's more to it. So fortunate enough to have sent whole genome sequencing rather than targeted genetic testing. And after a few weeks, we got the result. So the lab technician from Dante told me that they found something called as NCF1 mutation, and it's chronic granulomatous disease. I was like, what? What disease? So this is where the clinician's professional ego getting hurt. I was so sure that this was hyper IgE syndrome, and because of that bias, I even managed to ignore the fact that the child did not have poorly controlled eczema, which is usually a part of hyper IgE syndromes. So I took the phone. This phone is an important thing by which we resolve clinical mysteries for our patient. Spoke to the scientist in Dante, and I said, "Are you sure this is not fitting with my clinical phenotype here?" And just put some pearls all along the way, just to tell you what are the important learning points from it. So bear in mind, for those of you who are not mainstream practicing clinicians, the way, although we say that medicine is all about pattern recognition, bear in mind the way clinicians build their patterns in their head could be flawed. So here, I immediately made a wrong type 1 cognitive error by thinking that this is hyper IgE syndrome. So the reason our patterns are wrong is we have learned our patterns without the help of a huge missing piece, that is genomics. So we've so far described our patterns without the benefit of genetic diagnosis. So that's why we get it wrong, the pattern recognition. And the other learning point is the phone, as I said. It's very, very useful if we discuss cases with each other. And again, the lab gave me the details of the mutation that was found. It was autosomal recessive in homozygous state, and it was classified as pathogenic. And I was not still satisfied, so I asked her, I made sure that you haven't missed scan gene of 8, type 1, type 2 mutation, as you said, yes. So, and this is how biases are broken if we do a good literature search. Okay? So the same scientist who was helping me brought out these papers where there were reports of significantly elevated IgE levels in chronic granulomatous disease. So what we don't know, we don't know. So I hadn't heard of that, so I was biased in that way. But there were several reports on that. But clinicians, we are front-facing professionals. The stakes of calls that we make are huge. So we want to further confirm it. So I was not satisfied. So I looked up whether there was any other lab-based or molecular ways I could confirm this diagnosis. So chronic granulomatous disease actually causes a defect in oxidative burst in your phagocytosis. So you can confirm this by measuring the oxidative burst in your cells. So there are two tests that we used. So nitroglycerol test and dihydroguanidine test, which demonstrated significant abnormality in oxidative burst. So now I was satisfied. So we have a phenotype, a genotype that matches, and an independent lab test that confirms it. And so that I could confidently classify this as an actionable diagnosis now. So another thing about reporting, when we do a proactive whole genome sequencing, this is what the report will look like, running into several files or PDFs, and it can be quite overwhelming for clinicians before we have 20 minutes to deal with patients. So that was one of the reasons I was slightly skeptical of the report initially. Kindly we provided a summary of what were the pathogenic variants, and even some of them didn't seem relevant to the clinical case. So I asked the lab to give me a clear clinical report. So when you do whole genome sequencing, you have to ask the lab what you want to see. So they gave, this was the third part of the report, which made it very clear, and the basis on which they had classified this as pathogenic. So I was visiting the variant annotation workshop earlier, just to see what goes on in the background, not because I could solve any of those variant annotations. So I was fascinated by the amount of work that goes on behind the scenes to produce such reports. But bear in mind, the clinicians don't know any of these. So you have to explain to them why you have called it as a pathogenic variant. So this, coming back to this child, so because this condition affects phagocytosis, it affects multiple organ systems in the body, like lymph node infections, lung infections, skin infections, colitis, bone infections, etc. And what statistics show is, as soon as you diagnose them, you have to put them on prophylactic antibiotic and antifungal medications. If you do that, you can improve the life expectancy from 20 years to 40 years. So even with that, the life expectancy is 40 years old. But there is a curative treatment for this condition in the form of stem cell transplant. So we referred our patient for stem cell transplant, which he is waiting for now. Another really useful thing that we should take for future from this experience was they also did pharmacogenomic analysis for us, and they found that a medication called voriconazole, the child would actually be an ultra-rapid metabolizer of voriconazole. So voriconazole would be a commonly used antifungal in this scenario, which means that even if we use high doses, there's a possibility that we may not be able to get therapeutic effect with voriconazole. So when we had to treat it, we instead used other medications like caspofungin. So this story actually summarizes all the things that we were discussing. And the family was eventually very happy with us for having made a diagnosis eventually in 3 years. But the question is whether we actually did a good job. Soon after we referred this child to for the bone marrow stem cell transplant, we presented with recurrent fevers. But this time the advantage was we knew exactly where to look for. That's again the benefit of precision diagnosis. We know where all infections can come in this condition. So we did an abdominal MRI which picked up fungal abscesses in the spleen and kidney. So the reason I described that this was not a happy story is it takes months and months and months to clear fungal, deep-seated fungal abscesses. Because unless you clear that, if you blast it with immunosuppressants before stem cell therapy, there's a long flare-up battle and the child might die. So we've actually lost valuable time to cure him with stem cell treatment. So the question is, can we actually rewrite the story? Do we have the capability to rewrite the story? The answer is yes. Imagine this child is born, and we had a genome screening program in which primary immunodeficiency causing conditions like CGD was involved. Soon after he was diagnosed, we could actually put him on antifungals and antibacterials, preventing all those infections he had, and also potentially protecting him from deep-seated fungal abscesses. And we could have focused on referring him directly to stem cell transplant, and the story would have been probably a happier one. So we want to highlight that we are in a day and age where we can have rewritten the story in a better way. So quickly, going through the learning points from this story. So clinicians do make a lot of type 1 cognitive errors. We don't know what we don't know. So that's where the utility of wider tests like whole genome sequencing comes. Otherwise, we're just perpetuating that diagnostic literacy more and more by doing targeted testing. Then communicate with labs to help in variant validation. So the way the labs understand phenotype is very different to how you understand phenotype. So, and the way you understand like a clinician like me, understand variant annotation is very different to how labs understand it. So that collaborative communication actually helps in resolving lots of mysteries. And also ask the labs for the kind of reports you want. And again, pharmacogenomics will potentially become part and parcel of our day-to-day clinical practice in the near future for the good. So if you look at what the advent of genomic medicine has done to me as a clinician, this helped me unlearn and relearn lots of concepts in medicine. For example, lots of concepts we learned about epilepsy, for example, were proven to be wrong when neuroendocrine genetic diagnosis came about. And I feel like I've become a more empowered clinician because not in my remote dream, I would have thought of diagnosing a child with chronic granulomatous disease within 1 month of having seen him. So yes, immunologists and infectious diseases specialists can do it, but a clinician who predominantly does genetics and immunology, I don't think I could have done it without the help of this powerful test. And I am a strong advocate of early genomic screening and testing, and we have to bring the genomic testing much earlier in the list of investigations that we do. And I'm quite hopeful of curing lots of conditions that we thought were incurable previously. For example, SMA, Duchenne muscular dystrophy, and currently there are some gene therapy trials going on in Dravet syndrome. So lots of things that we thought previously couldn't be cured can now be cured. And that again emphasizes why we should get diagnosis in the first place. But scopes and challenges very quickly. I kid you not, there are lots of people who think that we who gathered in this room, our ultimate goal is to create dinosaurs from prehistoric mosquitoes. And there are lots of skeptics of genetics, and for a valid reason. So what I want to say is, what do we have to do in order to advance this smoothly? So let's look at the scopes and challenges. So there will be an explosion of information in the next few years, because several different hospitals and centers are undertaking wide genomic testing. So clinicians will be put in this position of we need to interpret genetic testing more and more. So mainstream clinicians like me have to be more and more genetic savvy now. We have to relearn genetics to help our patients. Then we have to overcome the pros and cons of getting early genomic information. For example, newborn genome screening. How do we deal with it? Because these are children who don't have phenotype. Is it helpful or harmful? So again, coming back to how we format our reports, it has to be on the money, that it should not be a document that freaks out parents, but it has to be useful. So we need to collaborate and think about how we present the data from genome screening programs. And the combination of AI and machine learning and genomics, as several people have highlighted here, this is going to further produce a chain reaction in how we understand conditions, because there's the capacity to do wide analysis of genome to genotype to phenotype correlations and pattern recognition. So variant validation. So the biggest bugbear of lots of skeptics of genetics is when they report, say, lots of variants of uncertain significance. So the clinician, geneticist, and the lab staff has to be inquisitive about what is the relevance of this variant, and we have to proactively think of advanced technologies like functional analysis using protein markers of conditions and genetic changes and metabolites. Then another big challenge that we have in front of us is how we deal with medical insurance. So those of you who work in the private sector would know that lots of medical insurance actually do not cover genetic conditions. So, and that we have to jointly deal with using political support and medical campaigning. Because at the end of the day, majority of conditions will have genetic basis. Even asthma has genetic basis. So are we going to say that in future, medical insurance wouldn't cover things like asthma? So we have to make a paradigm shift in how they define this exclusion process. Then we will be prescribing precision genetic therapy much more on a day-to-day basis in the near future, because if you look at the speed at which newer and newer genetic-based drugs are released now, this is going to be a common practice in the near future. And finally, if I was to make a dream or wish about how my practice would look like in the future, this is what I would want to see. All babies born soon after their birth, they get genetic screening, and reporting will be absolutely gold standard. There's no room for ambiguity, and it will be a useful, actionable report. So that's what we have worked on. And the way we produce such reports is by good communication, being inquisitive, and also utilizing the next generation of variant validation, uh, like functional analysis using proteomes and metabolomes. And those patients who can be treated with precision medicine, which should be existing medicines which are repurposed, or new medicines, or gene therapy as well. And having access to the genetic data. So those of you who might know, in India there's a practice called as writing horoscope. So people in India believe that alignment of stars and stuff influence what happens in your life. And they reanalyze that when the person is going to get married or going to take a job and things like that. So if you can have access to the data to reanalyze it, that would be what we need. And future direction, we've only talked about things related to genetic changes. What about epigenetics and RNA epigenetics that influences diseases? So thank you so much for your time.